Hi, good afternoon, everybody, and a really warm welcome to our Ask the Expert session this afternoon. I'm Helen Dickens, I'm Director of Programmes at Target Ovarian Cancer, and I'm really thrilled to welcome Dr Rowan Miller, Consultant Medical Oncologist, who is going to speak with us today about genetics and targeted treatments. We're really looking forward to a great session. First, we're going to hear directly from Wendy Howard about her personal experiences in undergoing targeted treatment. And then we'll hear from Dr Rowan Miller, who will lead on a presentation to offer evidence-based information on genetics and targeted treatments. And after hearing from our experts, you'll have the opportunity to put your questions forward as well. I will, of course, ask Wendy and Rowan to introduce themselves in a moment. But before that, I just want to take a couple of minutes to run through some of the practicalities of today's session. So thank you so much for all of the questions that you have sent through to us in advance, and we will pose as many of these as we can to our speakers today. Although we may not have time to get through all of them, we will do our very, very best. So as I said, we may not have the opportunity to answer everyone's questions today. It's a really big topic, and we do only have the hour. But I'd just like to reassure you that if we can't answer them right now, then our support line is always available to help with your questions, and we'll provide a reminder of how to get in touch with us at the end of the session. And of course, if you don't want to ask a question today and you're here just to listen, that is absolutely okay too. So before we start, I'd like to remind you just to remember that everyone here has really different circumstances and situations. So the things you hear, particularly about treatments available or what to expect in the future, might be relevant to you or your loved one, but they might not. And likewise, everyone's at a different stage and coping differently. So please do keep this in mind and respect everyone's views and concerns. We really want to ensure that this session is a safe and positive space for everyone that's taking part. If you are taking part as a friend or a family member, we also ask that you don't ask questions based on your loved one's specific circumstances without their knowledge and permission. I also need to remind you that anything that comes out of today's session isn't medical advice, and it's definitely not a substitute for the information and advice that you've been given by your own clinical team. We won't be able to answer very specific questions today about your own individual circumstances, but hopefully from the session what you'll get is an overview for any conversations or questions that you might want to have with your own clinical team. So again, if anything comes up today that you're not sure about, if you're not sure about what it means for you or your loved one, or it prompts any questions or concerns or anything that you'd like to discuss further, please don't forget that you can call our support line and get more information and talk about anything that's concerning you. We will add the number for the support line to the comments. So without further ado, I want to get us started. So I'm really excited to hand over, first of all, to Wendy and hear about your story, Wendy. So over to you.
I'm Wendy. I'm nearly 62 years old. My story started 16 and a half years ago when I was diagnosed with triple negative breast cancer and had a left mastectomy and chemotherapy. And fortunately, to this day, it hasn't returned. But just over 4 years ago, I was diagnosed with stage 3A ovarian cancer. And it was actually strangely picked up on a smear test, which is quite unusual. And I had a 24-centimeter tumor. So I underwent all the radical surgery and the chemotherapy. And then when I'd finished my treatment, there was no evidence of disease. But I was then diagnosed as being BRCA1 positive, now, which explained the previous breast cancer. That had a huge knock-on effect for my family because all of our 3 children had a 50% chance of inheriting the gene, and all 3 of them have got it. So within the next year, my daughter underwent a preventative mastectomy, and my son had 2 lots of skin cancer. And my niece, age 28, had been being treated for IBS for a year. And at the age of 28, they discovered that she had stage 1C ovarian cancer and a 16-centimeter tumor. So it was pretty full on, the BRCA diagnosis. So I was then fine until December 20, when my CA125 level was rising, and a scan showed that the cancer had returned. So I had a very enlarged lymph gland in my abdomen, a grey area outside my liver, and cells in the peritoneum. So, of course, I was back on chemotherapy then for the third time. So I went through the chemotherapy. Halfway through, it was one of my lowest points, I think, to find out that there was no change in the scan. And when the scan had finished, there was a small improvement. And it was at that point they put me on olaparib. Now, that was 10 months ago. And I was really scared about going on olaparib because you read all the negative effects and how it can affect your blood, etc. But after the first couple of weeks, a few headaches, a little bit of feeling a bit yucky, I actually felt fine. And I can honestly say for the last 10 months, I felt fantastic, really fantastic. It hasn't stopped my life in any shape or form. My CA125 is 3. And the olaparib is definitely working tremendously for me, because even though the chemo didn't diminish the cancer, the olaparib has done, because the cells I had have disappeared, and my lymph gland is the only thing remaining, which is less than 1 centimetre and not measurable. So the consultant on the last scan said I had no sign of active cancer. So really kind of feel quite privileged actually to be on this treatment, and feeling so well and living a really positive life at the moment. So I'd probably just end for people with a couple of tips that I found useful. I never ever Google anything negative, statistics I don't want to know. I Google information that's positive for me, how I can help myself, diet, exercise, just general well-being. And I always have lots of things to focus on, so I try and keep myself really positive. And I'm very, very much my own advocate. I chase up appointments, I push along scans, etc. And I just read up on stuff that I think will help me. I don't sit back and wait for things to happen. I've had quite a lot of letters lost through doctors, etc. So I chase things up and I try and give myself that little bit of back control that we don't generally have. But I'm just pleased to say I'm over 4 years down the line from advanced ovarian cancer, and at the moment I think I'm doing really well. Is that okay?
Thank you so much, Wendy, for sharing that. And yeah, sounds really positive news. So thank you. I want to hand over now to Dr. Rowan Miller to talk in a little bit more detail, but I'm sure everybody will share me in thanking Wendy for taking the time to share that story this morning. And of course, if there are any questions or thoughts, then we can address that later on in the session. So if I could hand over now to Dr. Rowan Miller. Rowan, I'll leave you to introduce yourself.
Thank you. Thanks very much. Thanks so much for inviting me to speak today. And Wendy, thanks for your story. It's really nice to hear that you're tolerating the treatment well and it's made a big difference. And I hope that that's what I can show to you today, the difference that using genetics and targeted therapy has made in the management of ovarian cancer. So my name's Rowan. I'm a medical oncology consultant. I specialise in gynae oncology, so mostly ovary cancer, and I work in London. I spend half my week at UCL Hospital and the other half at Bart's Hospital. And we're going to talk today about genetics and targeted therapy. Thanks so much for all your questions that you submitted in advance. I have tried to include the answers to these as much as possible, but we have plenty of time at the end to go through anything that isn't covered. So just as an overview, what I'm going to talk about this afternoon is, when we talk about genetics, what do we mean? What are genes and why are they important for cancer? What is targeted therapy? And then give some examples of targeted therapy that we have available to us for the treatment of ovarian cancer. So PARP inhibitors like olaparib that you've just heard about, also immunotherapy. And then at the end, I'm going to talk a little bit about some of the genetics and some of the rarer types of ovary cancer, which perhaps historically haven't been so well researched, but there's a lot of exciting things coming through. So when we talk about genetics, what do we mean? Well, we're talking about genes, and genes are the backbone or the building blocks of everything that exists. So humans are made up of hundreds of billions of cells, and cancer as well is made up of hundreds of millions of cells. And the cell is the kind of smallest molecular structure that exists. Within the cell, we have the nucleus, and that's the kind of brain or the control center of the cell that manages what the cell does, how it divides, how it grows. And this is a completely normal process. And within the nucleus, we've got our chromosomes. So in humans, there's 23 pairs of chromosomes. And in each chromosome, there's meters and meters of DNA really, really tightly coiled up. And it's this DNA that has the genetic information that houses the genes. That's what makes us who we are and what makes a cancer what it is. So the DNA is two sort of backbones, a bit like a ladder, and then these pairs across of nucleotides that can come in hundreds of different sequences, and it's a proportion of DNA that makes a gene. So a gene can be anything from 200 bits of DNA to up to 2 million. And there's, genes generally encode proteins which have a function within the cell, but there's many hundreds of genes that we don't really know yet what they do. So in a human, we probably have between 20 and 25,000 genes in a normal human. And any abnormality in a gene is called a mutation. That's the terminology that we use. And it just means that the DNA is not quite normal. So sometimes a mutation in a gene might have no consequence. So although the DNA isn't quite normal, it doesn't actually affect what the gene and the protein does. But sometimes this can have a huge impact on what the gene does. And it can have very deleterious effects, particularly when we talk about cancer. So any one cancer can have up to 10,000 mutations in an individual cancer. So 10,000 mutations, that could be in 10,000 genes or many mutations in single genes. But not all mutations are that important to cancer. So some are more important than others. So one mutation in a cancer, it might give it an advantage. So it might help the cancer grow and spread, or it might help the cancer get more blood supply, which it needs to survive, or it may allow the cancer to become more resistant to treatment. So the type of mutation and the gene that it is in is important. And that then defines what would be what we consider a target for targetable treatment or non-targetable. So some genes that might be mutated in cancer, they actually don't do anything that important. So there's no point targeting them. But some of them are critical to the cancer, and they're the ones that we want to target. And they're the ones that we want to develop treatment for. And when we think about mutations in cancer, there's two different types. So the majority of mutations in a cancer are just within the cancer, but rarely we see something called a germline mutation. So this is a hereditary mutation. It's, as Wendy described, something like the BRCA gene can be hereditary. It's found in every cell in the body, and it leads to an increased risk of developing cancer. But if you develop cancer, the cancer will also have that mutation, because the cancer is just an abnormal version of a normal cell. So you can detect a germline or a hereditary mutation by doing a blood test or by taking a sample of the tumor. But most of the mutations we think about in cancer, and most of the relevant ones, more than 99.9% of mutations in cancer are what's called somatic mutations. So they're just in the cancer. They're not hereditary, they're not in the blood, but they've developed as the cancer has evolved over time. And as I said before, there can be up to 10,000 mutations in an individual cancer. So they're the ones we're interested in when we think about treatment. Obviously, the hereditary mutations are important in terms of implications for family members, but it's the tumor ones that we're thinking about when we're thinking about new treatment. And when we talk about targeted therapies, these are different from chemotherapy. So targeted therapies act on a specific molecular target or abnormality within the cancer. In comparison, chemotherapy works by killing cells that grow fast, and cancer cells grow faster than normal cells, which is why chemotherapy works. But targeted therapy, you're exploiting a specific weakness in the cancer cell. So sometimes we might be blocking something that's overactive and is increased in the cancer, so you stop it and it stops the cancer cell growing. We might exploit a weakness in the cancer cell, such as with DNA repair, which you'll see when we talk about PARP inhibitors. We might be inhibiting the cells that support a cancer, so not the cancer cells itself, but for example, a cancer needs to get its own blood supply to grow, and some of our targeted therapies, such as bevacizumab, work by blocking new blood vessel formation. Or we might target immune cells, which help kill the cancer. So there's lots of different types of targeted therapy, and it's really a broad term that covers a whole load of basically any drug that's not chemotherapy. And the ones that are particularly relevant are in ovarian cancer. So some are licensed and some are sort of in the research stages. So PARP inhibitors are particularly relevant for BRCA cancers and for those with homologous recombination deficiency, which we're going to discuss. Immunotherapy is relevant for a very small but important subset of ovarian cancers that have got this thing called mismatch repair. And then there's a number of other mutations in other cancers that will predispose to using targeted therapy. So I'm going to start by talking about PARP inhibitors and BRCA and HRD. So BRCA1 and BRCA2, these are genes that are often mutated in ovarian cancer, particularly high-grade serous ovarian cancer. And we have for several years been able to test for BRCA mutations. And now these mutations can be hereditary, as we heard from Wendy. So these can be passed down through families and are associated with an increased risk of ovary cancer, but also breast cancer. But we can also get these mutations that are just present in the tumor. So they're not hereditary, but they can arise in the cancer. And overall, about 15 to 20% of all high-grade serous cancers will have a mutation or abnormality in the BRCA1 or BRCA2 gene. So if I take you back to this picture I showed you before, when we talk about BRCA, as I said, the inherited mutations, they're found in every cell in the body, and about 15% of all patients with ovary cancer will have an abnormality in the BRCA1 or BRCA2 gene, which we can detect with a blood test. And then in addition to that, another probably about 5 or maybe as much as 10% of ovary cancers that have developed will have a BRCA mutation, but that's only present in the tumor, not in the blood. So overall, about 20% or 1 in every 5 ladies with a diagnosis of ovary cancer will have some kind of BRCA mutation in the tumor. And that BRCA1 and BRCA2, they're 2 separate genes, but they have the same function. So when we talk about BRCA, we mean both of them. And just a little bit on hereditary BRCA1 and BRCA2, we could speak for hours on this, but I'm just going to highlight some key points. The most important thing to remember is most people with ovarian cancer do not have an inherited risk factor. So although in a small number of patients there is an inherited risk factor, the majority of people this BRCA test will be negative, and therefore their family is not at increased risk compared to the general population. One of the reasons that we do testing for the genetics is not just for treatment for patients, but also does have implications for family members. And doing testing allows relevant family members to be screened or to undergo preventative strategies that we've heard a little bit about from Wendy. So it's all about identifying the gene and preventing other people getting cancer. I mentioned here just very briefly RAD51C and D, sorry, it's RAD51, not 15. These are an extremely rare cause of hereditary ovary cancer, and we don't routinely test for it. But in anybody who had a very strong family history of ovary cancer but was BRCA negative, we would refer to genetics, and that's something else that could be tested for. And it has the very same, in terms of effect on the cancer, it's very similar to BRCA. It does a very similar thing in the tumor. And if you want any more information on BRCA, as I said, we could talk about this for a long time, but speak to your oncologist or your clinical team, and there's loads of really good information on both the target ovarian cancer and the Macmillan website about hereditary BRCA1 and BRCA2. But as I said, the majority of people do not have a hereditary ovarian cancer. And this is just to say that the terminology that we use is really confusing, and I'm as guilty as everybody else. So you will hear various terms bandied about for a mutation. So BRCA mutation means an abnormal BRCA gene, but sometimes we'll call that BRCA positive, as in it's a positive mutation, and sometimes we'll call it BRCA deficient because the protein isn't working, and sometimes we'll just call it BRCA. So it can be really confusing, and I apologize for myself and on behalf of all my colleagues because we're really inconsistent with the way we talk about genes. And it's the same for if you're not BRCA. So the technical term for having a normal BRCA gene is BRCA wild type. But we might say that's normal, or we might say it's BRCA negative, or we might say it's non-BRCA. So you may see terms like this, on letters to GPs and things like that. And I apologize that we're not consistent, and sometimes it can lead to a lot of confusion about what it means. Why BRCA is important when we think of targeted therapies is because of the advent of PARP inhibitors. So PARP inhibitors, they're tablets or capsules. They inhibit this protein called PARP, which stands for poly-ADP ribose polymerase. As I said, it's a type of targeted therapy. It's not chemotherapy. It's nearly always used as maintenance treatment. So following chemotherapy, to maintain the benefit we've got from chemotherapy, we treat with PARP inhibitors. It's not given instead of chemotherapy, it's given in addition after a response to chemotherapy. And there's 3 PARP inhibitors available for the treatment of ovary cancer: olaparib, niraparib, and rucaparib. Now, these are essentially the same drugs made by different companies. They have a slightly different side effect profile, and the times that we can use them is slightly, there's various patient factors or disease factors that dictate which ones we can prescribe, but they're all essentially the same drug and they're equally effective when we use them in the same situation. So one is not better than the other. They just have slightly different side effect profiles. And for example, niraparib you take once a day and the other ones you take twice a day. But really, there's not one that's better than the other. They're just used in slightly different situations. And how do they work? Well, I'm going to go through a bit of basic biology. So I do apologize, but I think this just helps understand the way that targeted therapy works. So our DNA, the thing that makes up the genes, is constantly under attack. So external sources from the body, so radiation, UV light, viral infections, chemicals, all of that can affect our DNA. And also things within the cell, so just the process of dividing all the time can cause damage to the DNA, stress of replication, oxygen radicals generated when a cell divides, all of that can damage the DNA. And our DNA in our bodies is probably subjected to hundreds of thousands of bits of damage every day, but we're very well equipped to repair that, to stop damage accumulating. So the DNA is a double strand, so you can break in a single strand, which is actually quite easy to fix because you've got the mirror image template strand to copy from, and there's lots of different ways the cells can do that. But if that single strand break isn't repaired when the cell divides, that can then become a break in both strands, or you can get a break in both strands from any one of the types of damage. And these are a bit more complicated to repair, but it's still very well equipped to do that. So there's 2 types of double strand repair break. One is called homologous recombination, and the other one's called non-homologous end joining. And the one that's important on ovary cancer is this one, the homologous recombination. So you've already heard me mention homologous recombination deficiency. That means this type of repair doesn't work. And we've known for a long time this is relevant for ovary cancer because BRCA1 and BRCA2 are the key proteins in controlling homologous recombination. So if you've got BRCA mutation, you haven't got homologous recombination working as well, so you're more dependent on the other types of DNA repair. And that's particularly relevant because PARP inhibitors, they inhibit this protein called PARP, and PARP is very relevant for the single strand repair mechanism. So if you treat a cell with a PARP inhibitor, you get this accumulation of damage to the DNA, which in a normal cell would be okay, but in one with a BRCA mutation, it can't fix its DNA properly, and you get this massive accumulation of damage, which ultimately leads to the cell dying, which is why PARP inhibitors work so well in BRCA cancers. So just to really simplify that, this is a concept we know in science called synthetic lethality, but basically if you have a normal cancer cell and BRCA is normal and PARP's normal, so A and B, the cell survives. If you knock out BRCA because of a mutation, but you've still got PARP, it's okay, the cell survives. And similarly, if you treat with PARP, but the BRCA is normal, then the cell survives, but it's only if you take them both out that the cancer cell will die. So you can lose one or other, but not both. Like if you have a table with 4 legs, if one leg falls off, it will still stand, but if the second leg falls off, then the table will fall over. So you can live without one, but not both. And as I said, that's why PARP inhibitors work so well in BRCA-mutated cancers. But we know that only about 1 in 5 cancers are BRCA mutant, so what about everybody else? Well, this pie chart is it's data now, it's a decade old. It's from the Cancer Genome Atlas, which was this big project where they did genetic sequencing on hundreds of thousands of cancers, every type of cancer. And these are the results from the ovary cancer one. So they took hundreds of ovary cancers and they did genetic sequencing and they looked at mutations that were common. So we know there's this cohort of BRCA cancers, but what they also found was that this whole sort of bottom chunk of the pie chart were cancers that had a mutation or an abnormality in one or more gene that was also involved in homologous recombination. So homologous recombination is that type of DNA repair that is so critical to cancers, to all cells. So basically, more than a half of patients are homologous recombination deficient. So just as Gina summarised, there's about 15% of inherited BRCA mutations, and there's a few more with tumour BRCA mutations, and then overall about half of all ovary cancers, particularly high-grade serous, are what we call HRD positive. So that's important because they also have the same benefit from PARP inhibitors. But how can we test for HRD rather than, how do we know that a cancer is HR deficient? And actually, it's a bit like looking for a needle in a haystack, that proverbial phrase. But if you think each one of these blue circles represents a different ovarian cancer, we know that a proportion of them will have a BRCA mutation, like 10, 12%. And then we know that there are a number of other genes involved, which may affect 1 or 2 patients in every 100. And you can see here that there's lots of different genes that could be involved. And it's not really practical to test for hundreds of different genes because they may only be abnormal in 1 in 100 or 1 in 1,000 cancers. And we don't really know, with the exception of BRCA1 and BRCA2 and maybe a couple of others, how important they are for homologous recombination. So we can't test for the cause of HRD, but we can test for the effects, what it does to the cancer. Excuse me. So because these homologous recombination deficient cancers, they can't repair their DNA properly. They get all this damage and they look really messy and scarred when you look at the genetics. And you can see this by looking at the chromosomes. So this here is the normal chromosomes, or the 2 arms and the 2 legs, and they are a mirror image of each other. And what you see if you've got an HR deficiency is you get these characteristic changes in the chromosomes. So they might, for example, drop a gene on one arm, so this orange A is gone, or it might change to a different gene, or you might get examples when one gene is doubled in a chromosome and removed in another, or flipped from one arm to the other. And you get all these sort of wonky changes in the chromosomes, which are very characteristic. And there are assays or tests available which look for these changes in the chromosome. So you're not looking what caused it, but you're looking at the effects. So they pick up the scarring pattern in cancer. And they will identify HRD cancers regardless of the cause. So whether it's due to a BRCA mutation or whether it's due to any other cause. And why this is really important is for the last 12, 18 months or so, the treatment of newly diagnosed ovary cancer is dependent on what the results of the HRD test as well as the BRCA test is. Because as I've shown you, the HRD and BRCA mutations cause this unique sensitivity to PARP inhibitors. And maintenance treatment after chemotherapy and surgery for a new diagnosis of ovarian cancer may differ. It might not, but it might differ depending on whether they're BRCA and HRD positive or negative. And this is now available in the NHS, but only for people with newly diagnosed ovarian cancer. Now, it may be in the future that it becomes relevant for recurrent ovarian cancer, but as yet there's no treatment in that setting that's dependent on HRD status. But for newly diagnosed ovarian cancer, we're routinely testing for HRD. And that's, as I said, because PARP inhibitors, what's available depends a little bit on the results. So in the first line setting, so when we say first line, we mean people with newly diagnosed ovary cancer who've had their chemotherapy plus or minus surgery. The treatment options for PARP depend on whether it's BRCA positive or HRD positive. So there are different options. So if you have a BRCA mutation, whether it's hereditary or just in the tumour, there's the option for olaparib on its own, the combination with bevacizumab, niraparib. I put bevacizumab in grey because BRCA mutants and HRD cancer should really have PARP inhibitors in this setting unless there's a good reason not to. And for HRD cancers, there's the same options, but not olaparib on its own. That's partly because when they did the trial with olaparib, they only included BRCA patients. So that's why that license is just for BRCA. And then if the cancer is HRD negative or sometimes called HR proficient, we still have the option for niraparib, which is a PARP inhibitor, which is shown to be useful in this patient population, this group of patients, and also bevacizumab. And there was quite a lot of questions on this beforehand. In the first line, so after chemotherapy and surgery, we only give PARP inhibitors for a set amount of time. And that's not a financial thing, it's to do with how the trials were designed. So in the majority, depends a little bit on which option you go for, but it's usually 2 years of PARP inhibitor treatment. And that's because we know that covers the time which is the higher risk for recurrence, and also although these treatments are well tolerated, we don't want to give them indefinitely if we don't have to. So after initial diagnosis, we only give PARP inhibitors for a set amount of time. In the second line or beyond setting, so if someone has cancer that's come back, which has responded to chemotherapy, and we start PARP inhibitors, we've got the option for all three. It's not dependent on BRCA status or HRD status. And in this case, it's given indefinitely. So in ladies who have been treated with PARP because the cancer's returned, we can give the PARP inhibitor indefinitely. And in fact, we've got a number of patients who are on the first trials who've been on it for 6 or 7 years who are doing very well. So it's slightly different, the timings that we give it for, depending on when we're giving PARP inhibitors. So moving on from PARP inhibitors, I'm just going to touch on briefly on immunotherapy and ovary cancer. So there's always I get a lot of questions about immunotherapy because there's a lot of information on it on the internet and in the news, and immunotherapy really has revolutionized the treatment of some types of cancer, so skin cancer and lung cancer. In ovary cancer, as yet, it has not been particularly successful because in general, ovary cancers are not particularly what we call immunogenic. And immunotherapy, just for those of you who are less familiar with it, we probably all develop tiny cancers all the time, but our own immune system, which swims around the body, would recognize these cells as foreign and destroy them, like it would if you have a viral infection or a bacterial infection. But for cancers to grow and become established, they build up this almost protective shield, so they're hidden from the immune cells. And how immunotherapy works either breaks down this shield, either on the cancer side, or it activates the immune cells to recognize the cancer cells and then destroy them. And because in general, ovary cancer doesn't have a lot of immune cells in it, immunotherapy hasn't been particularly successful, but there are certain groups where it is successful and there's definitely a role for it. And one of these is the mismatch repair deficiency. So that's another genetic abnormality. So this is the slide I showed you before, but here you can see that mismatch repair is another type of DNA repair. It's involved in single strand breaks. And there are a number of genes involved with it. So MLH1, MSH2, MSH6, and PMS2, they are all involved in mismatch repair. And what they do is if you've got your double strand and the bases don't match up, i.e. they're mismatched, it goes and fixes it. And it maintains the genomic integrity. And if it's deficient, you don't get proper repair and you get this buildup of what we call microsatellite repeats, which can be detected. Like all mutations, they can be hereditary or cancer specific. They're most commonly cancer specific, so they're not hereditary, but occasionally hereditary mutations in any one of these mismatch repair genes can predispose to something called Lynch syndrome. Now, this is a hereditary syndrome. It's much more commonly associated with bowel cancer and endometrial cancer, but rarely people with Lynch syndrome can develop ovarian cancer. The tumor-specific mutations are much more common in clear cell and endometrioid ovarian cancer. So about 10% of these cancers will be what we call mismatch repair deficient. It's very uncommon for high-grade serous cancers to be mismatch repair deficient. And why this is important for immunotherapy, because you've got your mismatched cancer, because they can't fix their DNA, they've got more mutations. So they look really abnormal, more abnormal to the immune system. So the immune system sees it as abnormal and therefore it sensitizes to immunotherapy. And in America, the FDA has approved a drug called pembrolizumab, which is an immunotherapy for any mismatch repair deficient cancer. It doesn't matter if it's ovary or endometrial or colorectal cancer. And these approvals are ongoing in the EU and in the NHS, but there are clinical trials available if you have a mismatch repair deficient cancer. And I should have said this is for treatment for cancer that's come back, not in the initial diagnostic time. And finally, I'm just going to touch on some rare cancers. So clear cell ovarian cancer is a less common type of ovary cancer, but there's a frequent mutation in a gene called ARID1A, and this is present in more than half of cancers. Sadly, this is my favorite gene. If you're allowed to have a favorite gene, I did my PhD on this gene exclusively, but this is it's involved in chromatin. It's when you pack up the DNA, this gene controls it. And we think from work done in the lab that it will sensitize to certain targeted drugs such as ATR inhibitors or immunotherapy. And there are a number of trials looking at this. So the PEACOCK trial is looking at immunotherapy. And actually this is just closed, but we hope the results should be available soon. And another trial that's been run by my colleague, Dr. Banerjee at the Royal Marsden, looking at an ATR inhibitor in cancers that are ARID1A deficient. And low-grade cancer, this is another less common type of ovary cancer. And we know here, this pictures of cells. So you've got the nucleus here, the sort of brain of the cell, and this is the outside of the cell. And the cells have these receptors on the outside. So what these do is any growth factors or hormones swimming around dock in here, and they set off this signaling pathway down to the cell, which makes the cell divide and grow. And at each of these stages, there's lots of different genes involved, and many of these are abnormal in low-grade cancers, particularly RAS and RAF. And that's relevant because there's a new drug called trametinib, which blocks this pathway here. So it stops the signaling from the outside to the inside and stops the cell dividing. And trametinib was shown in a trial in people who had low-grade cancer that had returned, that it controlled it for at least 6 months, or probably a lot longer than normal chemotherapy or hormone therapy. And we now have access to trametinib via the Cancer Drugs Fund. There's another trial looking at a very similar drug targeting the same area with or without another drug in combination that's ongoing. And then the other targeted therapy that's sometimes overlooked in ovary cancer is estrogen or ER receptors. So that's a growth factor. It's commonly upregulated in low-grade cancer, but actually also often in high-grade serous cancer. And we often use targeted hormonal therapy, so drugs that block the estrogen receptor, such as tamoxifen or letrozole in low-grade cancer, but increasingly we use them in high-grade serous as well. So that's another type of targeted therapy, and these are drugs that are more commonly associated with breast cancer, but can work very well in certain types of ovary cancer. I just wanted to finish with talking a little bit about clinical trials, because that's where we get the data that supports the use of this. This is a bit of a complicated figure, but basically this is a trial we're running just now. It's a big European trial, so it's looking at rare ovarian cancer. So unfortunately, high-grade serous is not included, but all other subtypes of epithelial cancer are included. And what we do, we do genetic testing of the cancer, and then depending on what gene is mutated, we allocate it to a treatment arm that's thought to match it. So if it's got what's called a PIK3 mutation, they get this treatment, BRAF mutation, this one, HER2, this one, etc. And this trial is expanding all the time. So there's another 4 lots of different treatment are about to become available. So this is really the way trials are going. So we're looking at specific groups of patients or specific groups of abnormality in the cancer and matching it to a treatment that we think will work. And there are lots of other targeted therapies in development for ovary cancer, which I didn't really have time to talk about today, but some of them, a lot of these have got trials that are ongoing that are recruiting just now: DNA repair, HER2, PI3K, folate receptor. We've also got targeted chemotherapies, whereby you target a specific abnormality in the cell and you deliver the chemotherapy into the cancer. So that's a nice new class of drugs that are being developed. And there's lots of stuff on immunotherapies and combinations that are underway. As I said, most of these, with the exception of PARP and some early immunotherapies, are still within the context of clinical trials. So we're really moving towards genetically driven treatment. If you've got any interest in a trial, I would recommend you speak with your oncologist, but there's loads of information about the trials running in the UK on both the Target Ovarian Cancer website and the Cancer Research UK website, and many hospital websites will also have details of the trials that they're running. But your oncologist is a good bet in the first instance to point you in the right direction. So I want to finish with some really positive notes. It's a great time to be involved in ovarian cancer research. We're really moving away from this one size fits all, everybody gets the same treatment, to using genetics to create different groups that might benefit most from different targeted therapies. And really using genetics and targeted therapies significantly improve the outcome and the options and the amount of different drugs that we have for people with ovarian cancer. So thank you so much for your time. I recognize that I've talked for a long time, so I'm really happy to take any questions.
Rowan, thank you so much for such a Detailed and informative presentation. I've definitely learned a lot from that, so thank you. We do have a short time for questions, and I see a number of people have been putting questions in the chat, so thank you. Please keep them coming, and if you're happy to, Rowan, we'll take a few questions.
Of course,
now.
yeah.
Brilliant. So we've had a question in the chat, and we actually had a few questions on this come through before the session as well. And I know that we've been focusing today really around targeted treatments, but I know lots of people have got questions around genetic testing and what it might mean for their family members.
Of course.
So particularly if they don't test positive for BRCA mutations, are there any implications for their family? So you've touched on it briefly already, but could you just reiterate your kind of thoughts around what people should be thinking about around genetic testing?
Yeah, of course. So we now, like I said, we've been doing BRCA testing for several years in most places, and normally, so if you have a BRCA test, if you do a tumour test and it's positive, we would then do a blood test, because not everybody with a positive tumour test will have a positive blood test. But if you have a positive BRCA1 or BRCA2 blood test, that will be about 12 to 15% of all ladies with ovarian cancer. That means that you have a hereditary risk for developing ovary cancer. It probably explains why you developed ovarian cancer. And for anyone with a positive blood test, we would refer to the local genetics team, who would arrange for family members to be tested. So if you have a positive blood test, there's a 50-50 chance that any siblings, brothers or sisters or children, would be positive. If they were tested and say negative, then the rest of their family, it doesn't skip a generation, it's either positive or negative. And anyone who was subsequently found to be positive would be referred to the appropriate screening program, depending on what their age was, what their sex was, etc. If your BRCA test is negative, which is the majority of people who we see, most people do not have hereditary ovarian cancer, then the risk to other family members is the same as the general population. So your children are not at increased risk. The one exception would be if there was a very strong family history, so lots of people in the family with ovary cancer or breast cancer, indeed any one specific cancer, but were BRCA negative. Sometimes we would, if there was a strong family history, would refer to genetics, and they might do extended testing, but that's a very small number of people. It's not relevant to the majority of people.
Thank you very much. That's really helpful. And again, if anybody's got any more questions about that, please do give our support line a call, and we'd be happy to talk that through in more detail. So Rowan, coming on to thinking about the targeted therapies that you've shared, and again, you've touched on this a little bit in your presentation, but I know we've got a number of questions around PARP inhibitors. And one of the questions that we've had through is, how long can somebody continue on a PARP inhibitor for?
So I think I covered that briefly. So if you have PARP in the first line, so after initial diagnosis and surgery and chemotherapy, for the majority of people, after your surgery and chemotherapy, there will be no evidence of disease. We would say you're in remission. In that case, PARP inhibitors are given for a predefined amount of time. It's slightly different depending on which PARP it is, but it's usually 2 years. So from completing chemotherapy, starting the PARP, you have 2 years of PARP inhibitor. That's certainly the case for olaparib. If you have PARP inhibitors because the cancer's come back and you've had a second or a third lot of chemotherapy and your own PARP inhibitor in that setting, it's indefinite. So for as long as it's working and you're tolerating it and you don't have side effects, you can stay on the PARP inhibitors indefinitely. And like I said, we have a few people who are on the original trials who've been on PARP for 7, probably 8 or 9 years now. So people can stay on it for a long time.
Thank you. And another question we had was, can a PARP inhibitor still be effective if your CA125 is significantly raised?
Yeah, so the value of CA125 is less important, is really what the trend of it is. So, that you could have 3 people who on the scan, they had similar disease, and one might have a CA125 of 100, one might be 1,000, and one might be 10,000. And actually the value is less important than what it does. So often when we start PARP inhibitors, the CA125 is still elevated, and we would usually see it come down on treatment. So that's not the reason not to have PARP. You have to have responded. The criteria is the chemotherapy has to have worked for you to have the PARP. So if the chemotherapy hadn't worked and your CA125 was rising, then PARP wouldn't be the right treatment for you. But if the chemo's worked, it doesn't matter what the CA125 is.
Thank you, Rowan. We've had a couple of questions as well around PARP inhibitors and breast cancer. So particularly for those who are BRCA positive, can PARP inhibitors prevent you getting breast cancer?
So that's a really good question. We haven't really been using PARP inhibitors for long enough to have a lot of good evidence to say that it definitely does, but we all think that it will do. So the first thing to say is that treatment for ovary cancer in a BRCA patient probably reduces your risk of breast cancer, regardless, the chemotherapy. The second thing is there are trials looking at giving olaparib as preventative strategy in people with BRCA to prevent them developing breast cancer. And it's likely that with time we'll see that using PARP inhibitors reduces the risk of breast cancer in a BRCA patient, but there's not good evidence to support that yet. But our feeling is that will probably be the case.
Okay, thank you. Sorry, we've got a lot of PARP inhibitor questions. I'm running through them. Please keep them coming. Thank you, everybody. You mentioned, or you talked about some of the rarer forms of ovarian cancer. And apologies if you've mentioned this already, but we've had a couple of questions about granulosa cell tumour and whether PARP inhibitors are appropriate in that instance.
So they're not, because they don't have the same genetic or molecular abnormalities as the high-grade serous. So granulosa cell cancers are not what we call epithelial cancers. They come from a different cell type. Now, there are targeted therapies against something called AMH in development for granulosa cell tumours. So there's a big French trial looking at that. So there are targeted therapies for granulosa cell cancers, but it's not PARP inhibitors. So they're exploiting another weakness in those cancers because they're biologically completely different, even though they come from the same part of the body.
Okay, thank you. And another question on PARP inhibitors. Why do they stop working?
That's the $1 million question. So sometimes they don't stop working, but as with all, not all, but as with lots of treatment, the cancer become resistant to it. So there's lots of different ways the cancer may become resistant to a specific treatment, and it's probably because it develops other mutations that allow it to circumvent. So, for example, sometimes the cancer can get another mutation in BRCA, which makes the BRCA start working again, having not been working. So you're restoring BRCA function. But there's loads of different ways that cancer can become resistant. And we're looking at ways to overcome that, either by giving PARP with another drug or by switching to a different strategy.
Okay, thank you. Going back to genetic testing, we've had a question through to ask if testing can be done retrospectively. So perhaps if somebody was diagnosed a few years ago and not sure about the status of some of the tests that you talked about.
So as I said, HRD testing can only be done for newly diagnosed people, so really people that were diagnosed in the last year, depending on where you're at with your treatment. BRCA testing, it should be possible to get BRCA testing if you haven't had it done in the past and you meet the criteria, which is any high-grade non-mucinous cancer is eligible for BRCA testing. So even if that wasn't done at the time of diagnosis, it still should be possible to do that. And certainly, now it's fairly universal, but maybe 5 or 6 years ago, it wasn't done quite so universally in all cancer centres.
Okay, thank you. We also had a number of questions coming through from people who've experienced a recurrence of their ovarian cancer, perhaps taking a treatment at the moment, a PARP inhibitor, and question to ask whether there's evidence of people experiencing long-term success in that instance, and what might be available if the PARP inhibitor ceases to work in the future.
Oh, there's lots of questions in there. So yes, we have a PARP. So if someone's on PARP inhibitors for recurrent cancer, yes, we see a lot of success with that. Like I said, we have people that have been on PARP for many years. And in fact, on the original trial with PARP inhibitors, I think more than 20% of people who were on it for either their second or third or even fourth recurrence were on it for more than 5 years. So definitely there are a lot of people that respond very well to it. If the PARP inhibitors stop working, it depends very much on what treatment you've had before, how long you're on the PARP for, but there would be other options in terms of usually chemotherapy or perhaps a clinical trial. And the third thing is that we are looking at whether if you've had PARP inhibitor before, and then you either have your 2 years and then need to have treatment again in the future, or it stops working and then you have more chemo, whether we can give PARP inhibitor again. And there's some suggestion that might be beneficial. So there's lots of trials looking at giving PARP again or giving it with something else or overcoming resistance.
Fantastic, thank you. And we've got a couple of questions coming through in the chat. They're coming thick and fast. Thank you, everybody. Just asking, do PARP inhibitors affect normal cells?
They do. I mean, everything, all targeted therapy, although it sounds magic and it's only going to affect the cancer cell, does cause some effect on normal cells. The most commonly with PARP inhibitors, what we see is it can affect the blood counts. So not to the extent that you see with chemotherapies, you don't get really low white bloods and platelets and things, but it can affect the blood count, particularly when you first start. So we monitor that quite closely when you first start. Yeah, so it can affect the normal cells, but the hope is with all these targeted therapies, it has more of an effect on the cancer cell than it does on a normal cell.
Okay, thank you. And so looking forward to the future, and I think you ended your presentation round on a positive note and where you see some of the developments coming. We've had a few questions about what might be going on or we could expect to see in the future from some of these trials. So a question come through around a potential vaccine being trialled for late stage ovarian cancer. You mentioned a few other areas. Where do you see some of the hope and some of the areas that we should be looking at for the future?
So, I mean, there's so many avenues that are looking really promising. It's hard to say which one particularly. I mean, I think vaccine therapy is an interesting one, along with the sort of immunotherapy combinations that need to be explored. I think one of the really positive things that we've done over the last few years is, 5 or 6 years ago, everyone with ovarian cancer was treated the same. It didn't matter what subtype you were, what your genetics were, and we've really moved away from that. And we're, increasingly personalizing options for people. So it's increasingly targeted to what your specifics of your cancer are. So by doing that, we're only going to improve outcomes. So we're individualizing treatment and taking the opportunities of all this amazing information we have from genetic testing and tumor testing. Yeah, it's difficult to say what I think the biggest advance will be, because there's so many things happening in all the different fields that I think we'll hopefully continue to see as many new drugs approved in the next 5 years as we've seen in the last 5 years.
Fantastic, thank you. And I'm afraid that that's going to draw our session to an end for today. I feel that we could carry on for at least another hour. So thank you so much, everybody, for your questions. A huge thank you, Dr. Rowan Miller, Wendy, for sharing your story and setting up the session so well at the beginning with your experiences. And thank you very much for taking the time to share that with us today. So thank you to all of you for joining us. There is a lot of information we just covered today. So again, if you are looking for more information about clinical trials, about any of the treatments that Rowan's talked about today, there is a lot of information on our website. If you haven't looked there previously, please do follow up on that. And of course, if we were unable to ask your specific question, or this has prompted lots more questions for you and your situation, then please do give our support line nurses a call. They'd love to hear from you. If you don't have the number already, it's 020 7923 5475. And they're available from 9 till 5:30 Monday to Friday. Please do give them a call. I'm sure many of you are already part of our regular events program as well. So our tea and chat sessions that run and our yoga sessions that run every week and fortnight. And we also have a coffee and chat session exclusively for partners, family and friends, happening on Monday the 21st of March, 6 until 7 p.m. So if that's relevant for you, please do consider signing up. It's a fantastic way to meet others and talk in a really supportive session. So just again, on behalf of Target Ovarian Cancer, I want to say a huge thank you to our speakers, to the team who set this up today, and also to all of you for joining us. Please take care, and we look forward to seeing you again very soon. Thank you.
Thanks for having me.